Thank you for joining us today for the NBHA Fracture Prevention Central webinar, Measuring Impact with Your FLS Program. I am Debbie Zeldo, Senior Director, Clinical Programs at NBHA. As many of you know, NBHA is a public-private partnership launched in 2010 that brings together the expertise and resources to promote bone health and prevent disease, improve diagnosis and treatment, enhance research, surveillance, and evaluation. With its collective reach of over 100,000 healthcare professionals and 10 million consumers, NBHA works to improve health and quality of life by enhancing bone health. NBHA currently has 55 organizational participants and 5 government liaisons that include CMS, CDC, NASA, NIH, and FDA, all working to achieve NBHA's 2020 vision to reduce bone breaks 20% by the year 2020. Fracture Prevention Central is one of NBHA's resources to achieve that vision and provides resources, tools, case studies, and webinars, both live and on demand, to help sites implement a fracture liaison service. NBHA has also launched a one-on-one technical assistance program through our FLS consult service. By completing a form on the NBHA site, as well as available on Fracture Prevention Central, we will connect you with an FLS expert for a 1-hour consult at no charge. Before we begin our webinar, I just want to quickly go over some mechanics. The webinar is being recorded and will be made available on Fracture Prevention Central as well as NBHA's YouTube channel. All attendees are muted and in listen-only mode. If you have a question, please type it into the chat box or click on the raise your hand and we will unmute you to ask your question. Now it is my pleasure to introduce today's speaker, Dr. Olenginsky. Dr. Olenginsky, you want to take it from here?
Yeah, thank you very much, Debbie. For those listening, thank you for listening. I hope to impart some practical information about what I consider to be the impact of measurements in an FLS program, and really what you'll learn about what you're actually doing. And really, in the absence of measurements, you really don't know what you're doing or what you're not doing. So I want to thank, again, the NBHA, David Lee, Debbie Zeldow, and I would direct anyone listening to the NBHA website, which is a wonderful site to learn about FLS and the impact of fractures, as well as many archived webinars, which really will point to key fundamentals that I think most speakers in the past and in the future will talk about.
Oh, awesome.
Let's see here. Debbie, I'm having trouble advancing on my side.
Okay, great. Let me take back control and I will got the slides and you can just let me know how to advance for you.
Yeah, okay, we'll go to the next slide. So over the past year, I've served as a consultant or speaker for Amgen. I want everyone to know that. Again, the focus of today's talk will be FLS, a database, measurements, and really using those measurements to set goals to improve an FLS's performance. Next slide. So we're going to quickly review the FLS concept. We're going to appraise differences among different programs. I'm really going to talk about our program, and I'm going to tell you that our program is in an integrated health system that has an electronic health record that makes it easy for us to communicate to doctors in our system. We can also easily communicate to doctors outside of our system because they select to get a communication. Now, these are sobering statistics. We know that 1 out of 2 women, 1 out of 4 men over the age of 50 will break a bone. Over 1/3 of patients with a hip fracture have had a prior fracture, and trust me, when I see many of these patients in the hospital, it is very frustrating and sobering to realize that they did not have an evaluation or treatment that could have potentially prevented the fracture that they are in the hospital with. We know every year 300,000 hip fracture patients, 1 out of 4 end up in a nursing home. 1 in 2 never regain their pre-fracture previous function status. We know that after a fracture, 4 to 5 women over 60 are not treated or tested for osteoporosis, the infamous HEDIS measure. We know that 50% of osteoporosis-related repeat fractures can be prevented, and we know that care is costly. Again, this really points to the need for a directed FLS program in any way that can be done in the community that a healthcare team is practicing. Next slide. Now, this is a summary article in 2006 from Seminars of Arthritis and Rheumatism, and it's a really simple article to read. It's a systemic review of over 200 publications that look to try to see if anything's done after some type of fracture identification. And the conclusion is really simple. Most patients are not receiving adequate osteoporosis treatment, and we clearly today have an armamentarium that's a little more fortified than what was available in 2006. So it points to the need for an FLS type of approach. Next slide. Now, this just emphasizes, this was an article that Dan Solomon wrote looking at, I believe, claims data from 8 major insurers and really pointing out that only about 20% of patients clearly that we would say need to be treated are in fact treated. So again, continued unacceptable, dangerous osteoporosis care gap. Next slide. I mean, with that background, that's the information that we knew in our healthcare system in, let's say, 2006, when we started to think about what we ultimately developed and started to run in 2008. What we wanted to do was try to reduce gaps and seize on what we thought we could do. And the first thing we did was understanding that we wanted to get to people in the hospital. We needed to create an outpatient pathway to take our patients identified in the hospital for subsequent care. We initially did that in our central institution in Danville, Pennsylvania, and we integrated it in 2 other geographic sites, and we also integrated it in certain other outpatient primary care sites in between those 3 major campuses. We understood that our primary care physicians at the time were actually doing a good outpatient job of appropriately using DEXA, looking to identify patients at risk for fracture, and instituting therapy in patients who were felt to be high risk. But we also knew the gap data, and we knew that we had no coordinated pathway of identifying fractures in our inpatient hospitals in our system. We wanted to take advantage of advanced practice nurses, physician assistants, nurse practitioners, and develop a collaborative team. And I'll tell you that our team in Danville is a little different than our team and our flow and how we utilize our resources in the Wilkes-Barre area, and it's a little bit different in the State College in Lewistown, Pennsylvania area. And we wanted to treat in sync with established Geisinger Health System guidelines, which really were guidelines that are endorsed by the National Osteoporosis Foundation and most major bone health care organizations. Next slide. So, I mean, understanding that we could not see every patient at risk, what we wanted to do was see patients who clearly should be on a treatment if there was no complication, if their doctors or other providers needed help or had trouble in a given patient. So those patients would be patients who had clearly a fragility hip or spine fracture, a patient who met a T-score threshold, a postmenopausal woman or man over 50 with a T-score at minus 2.5 or worse, someone who met a FRAX treatment threshold where they had low bone density and their FRAX score was either 20% major risk or 3% hip risk, or met a steroid treatment threshold. And recently, because of the work of the National Bone Health Alliance work group on a expanded clinical definition of osteoporosis, also incorporate today patients with wrist, pelvic, or proximal humeral fractures who have low bone mass. Next slide. And we said only if somebody wanted our services. We felt at the time, with the onset of parenteral therapies and likely evolution of a few other parenteral therapies, if somebody had intolerance to an oral bisphosphonate, in someone who was fracturing despite appropriate therapy, if someone had significant BMD loss that exceeded the precision or quality control figure at our DEXA Center with a negative secondary evaluation workup, patients with GI surgery, steroid patients, or just patients who were either difficult because they were hard to get on a treatment that they accepted and or tolerated, or they just needed more counsel, particularly regarding the perception that our therapies were in fact riskier than we seem to say, or just somebody that needed help in any other way. We actually identified certain departments where we just knew they wanted to send us patients independent of this. Those were our dermatology department, our neurology department, where they often used glucocorticoids. Next slide. What we did is we initially tried to gather information and arrange to have certain things done so that once we saw the patient, we could very quickly, at the time of that visit, get them on therapy or start a pre-authorization process for parenteral therapies. The other thing we did is arranged for someone, and that someone came to be about 9 months after we started this program, when we clearly realized we needed someone behind the scenes. Our two advanced practice nurses simply told us, we're busy, we need help, we can't get to everything that we need to do. So we hired someone who we really call our data coordinator, but she really has other functions, and she just kind of makes sure with task management software, with our database, that we're doing the right things, we're creating lists, etc., which we'll talk about in the upcoming slides. We wanted to call patients 3 months after they were started on an oral bisphosphonate to make sure they were tolerating it okay, to make sure they were taking it, to make sure that they didn't fall off therapy. Initially, we were going to get those patients subsequently followed in primary care, but as the long-term therapy or how long to treat question had emerged and continues to be a problem, we tended to say, let's embrace that, which was a way maybe to grow our program. Obviously, patients treated with parenteral therapies, we would at least see once a year to make sure that we would either continue that or recommend something different. And we really wanted to try longitudinally to follow these patients. Next slide. Now, we knew about the inpatient fracture problem based on the care gap data. And really, if you look at the problem is not really that, that orthopedists don't care about this, or that generalists or other specialists or other people really invested in this can't get to these patients. It was an ineffective process of care. So what we did is, as mentioned, we established an outpatient program. Then we developed an inpatient program really by talking to the key stakeholders, getting acceptance, and that was really orthopedics, our general medicine services, our hospitalist services, and really devising an auto consultation. So it is done all of the time. The only real difference, there's something on our auto consult that says if a patient has a certain level of chronic kidney disease, it's probably not appropriate for us to see that patient because there's probably going to be a contraindication. I'll tell you, we still get those patients, and basically we just notify nephrology that this is a patient that needs to be evaluated. And basically we wanted to marry the inpatient and outpatient pathway by integrating that throughout our system. Next slide. So again, any patient admitted over the age of 50 with fracture, we get to see an auto consultation is placed either by orthopedics, by one of our general medicine or hospitalist services. Exceptionally, our trauma services will sometimes consult us. We tend to get bare bone blood data. We get a calcium, a vitamin D, a 25-hydroxy vitamin D, because that just gives us a general sense of, is there an overt contraindication to our usual therapies. Vitamin D is really important in the medically chronically ill or obviously fractured patient population. We see the patients, we communicate to our HIROC coordinator through the electronic health record. We get the patient in our database and we try to arrange follow-up. What we've learned over time is that the 4 to 6 weeks may be sometimes 3 weeks, may sometimes be 8 weeks. We've also learned that it's very easy to somehow lose knowledge or lose kind of sight of where patients are based on complications, readmissions, where they go for either temporary skilled nursing, whether they go to assisted living, whether they return home, etc. Next slide. Now, what we've learned, and I think what mature FLS programs learn, is despite our best efforts, patients like their primary care physician, and they want to follow with their primary care physician. Now, when patients tell us that, we probably try to get them in, we try to explain to them why we think it's important that they follow with us, but many patients opt to say, I'm going to go back to my primary care doctor. When that happens, we send them a communication. We send them specific recommendations based on what we think is best at that time. What we initially tried to do is actually ask our system primary care physicians to send us a letter back saying we attest that we will do that. Primary care physicians are busy. That never really worked very well. But essentially, we thought this is the best that we could do. This is due diligence. And we follow those patients who opt to follow with us. What we don't know really is what happens to those patients who are followed subsequently by their primary care physician. We do think we know what happens when they follow in our system, but statistically, more patients who follow with their primary are actually followed by a non-Geisinger employed primary care physician, but they are in our area. So we still have at least the ability to communicate, but it's harder to really determine what happens over extended follow-up. Next slide. Now we're just going to go through our pathway. So, and I'm going to hit the next slide button. It's just going to say we identify patients by auto consultation. Deb, can you hit that, please? Okay, so we identify the patient. We do actually run fracture exception reporting. Exceptionally, maybe a couple times a year, we see that for some reason the consult wasn't placed, or it maybe came in on a Sunday and the patient was discharged without surgery and we missed them. We try to get them back. Next slide. We develop an initial plan in the hospital. Next slide. We get them in the database. We don't know about them unless they're in the database. Our database, as I'm going to show you, is really simple, but we think it's functional, and it gives us the ability to remind us what to do with patients at different points in time. Next slide. We come up with a final plan, and then finally, we think we see the patient in outpatient follow-up, and this is a seamless care pathway. Now, what I'm going to try to show you is a rather exhaustive analysis of how patients in what seems to be a pretty solid system fall through the cracks or potentially fall through the cracks. Next slide, please. And then one more. Okay. So if we look at our system-wide care at the top, we know that we've done a very good job doing DEXA in at-risk groups. That would be women over the age of 65. We had been doing a very interesting program in men over 70 who were identified by documented height loss. And prior to July 2014, we were able to use a height loss code that was subsequently retired. I've never known that a diagnostic code could be retired, but we ultimately found out from complaints that patients were getting bills that were not covered, that this program was in jeopardy. So we identified we studied 400 or 500 men, and basically, in essence, about 40% of the men studied by height loss, not a screening methodology. Height loss clearly is associated with more risk. We identified men, but we had to stop this because we no longer can use a height loss code today. Obviously, we look at patients with fracture on steroids, patients on androgen deprivation therapy or anti-androgen deprivation, patient with breast cancer on aromatase inhibitor. What's not necessarily shown is the primary care physician. We don't assume in our system that our primary care docs really do a very good job. We've done 2 analyses in the past looking at DEXA scans that were high risk, and basically throughout our system, 3 out of 4 times, a patient who should have been placed on a drug was placed on a drug. That's really, really good, and it's way above the care gap data. We obviously knew that there was a problem with the fractured patient, and again, next slide, Deb. That's why we developed the FLS concept, really developing an outpatient pathway, an inpatient pathway, and really keeping the primary aligned on that same pathway because, as I've told you, many patients opt to follow with their primary care physician. Next slide. Now, this is an article published in Osteoporosis International that really describes our program and really describes data from 2008 through sometime in 2011. The thing that I'll talk about again and again that makes us believe longitudinal follow-up is the way to go is if you look at those patients who clearly needed to be placed on a drug, and if you looked at whether we saw them in our pathway versus whether they saw one of our Geisinger primary care physicians, we got them on drug about 80% of the time. Now, the primary care physicians know what to do. They often don't get to see their patient who's fractured because of what happens, particularly after hip and vertebral fractures, but 32% of the time they were placed on drug if they were followed in our primary care network. We don't know about what patients outside of our network followed by their primaries, what happened there. It's really hard to really find that out. It's really that data that continues to make us think that ideally the longitudinal care design is best. And for those patients who follow with their primary, what we're going to talk about in the next several slides and really throughout the rest of this is this concept of safety nets. We know whether in our pathway or in primary care, patients are still going to fall out of care. They may not be identified even after we've seen them, even after we've communicated to the primary. Next slide. Now, the last thing I ever thought that I would be talking about is data. I'm not a database person. I'm in our health system, I'm called a frontline physician. I kind of like that. I see patients. I like to see patients. Seeing patients in the hospital with fracture who have comorbidities and who have barriers to ideal care at least makes me think about ways within the network that I practice in that maybe we can do it better. I think a database helps you coordinate care. If you don't measure something, you really don't know how you're doing. Clearly, a database helps with a HEDIS measure. A HEDIS measure is important, but really, it's really more important if we get that patient who's high risk on drug and we follow them and make sure that their care is properly followed and we treat them appropriately for as long as we think is medically appropriate. I think the Kaiser system is clearly shown in their single-payer system with an elegant database. They can monitor compliance, they can monitor drug holidays, they can monitor secondary causes of osteoporosis. What I think any database can help you do is to track, and if anyone would take anything from our experience and the experience of others, even under the best of circumstances, patients are human. For many reasons, patients fall out of a pathway, and even when they're followed in primary care, they may not be on a drug because of a number of factors, which we have to address, and we have to try to narrow that gap. Next slide. So this is just a case. This is a typical case we see. It's a woman, elderly woman, admitted after a fall, sustains a femoral neck fracture. We learned that she didn't have any prior fractures. She had never had a DEXA or a bone health prescription. We see the patient because our inpatient fracture identification auto consultation service works in our health system. Next slide. We obviously see a femoral neck fracture. We see that this patient has a little bit suboptimal vitamin D level. Her creatinine and calcium are adequate. She has a left hip hemiarthroplasty. Her vitamin D supplement is increased a bit. She's discharged to local nursing home for rehab. What we want to do is enter this patient into our database and make arrangements to try to get this patient treated. This is a clinical osteoporotic hip fracture. I don't need a DEXA to determine whether I want to treat this patient. I will recommend a DEXA to monitor the response to treatment, and perhaps, I mean, this is as severe a clinical osteoporotic problem as one can see, because this is the sentinel, the worst of the worst fracture. Next slide. So when we see the patient, we send a simple telephone encounter in our health record to our data coordinator, and then she puts the patient in the database, and then we try to do the right things thereafter. Next slide. This is actually what the initial inpatient data screen looks like. We use a very simple Microsoft Access database, and we simply want to get this patient in and make arrangements. Now, what we've learned, a lot of other things can happen. Number one, we forget to send a message to our data coordinator. Well, she has a double check in the background to remind us that we didn't do that. Okay. If we didn't have a database, it's harder, but I mean, goodness gracious, I wouldn't let a database stop you from starting a program. I would just say, as your program evolves, figure out a way of how you can track what you're doing. We clearly had staffing issues, and 9 months into our program, we hired someone to do this. And what we know is we sometimes, amongst ourselves, miscommunicate by not being really attentive to detail. If we see certain types of fractures, we already know, we see a hip fracture, or we see someone who's had a vertebral compression, or we see someone with a fracture who had a previous DEXA that already shows that they're at high risk. We see someone who has been on treatment but went off their treatment. What we want to say is, this is someone we know we need to treat. We just need to get them back and just discuss the things that we'd initially discussed in the hospital. Next slide. So again, what we have, and I'm not going to belabor this, we have a huge sheet of paper that goes across screens that has everything you want to know about a patient. We have certain things that prompt Karen behind the scenes to remind herself to do this, to do that, to get patients scheduled, to reassess vitamin D, etc. What I've learned over 8 years is that knowing what doesn't get done, so we know patients say no, so we've created a say no list. And then we're going to, we adjudicate that and say, okay, we're going to try to get this patient back. There comes a point in time where we say, patient refuses to come back, we communicate to their primary care physician. We are going to create a list that's going to say a Geisinger Health Plan patient who says no. We are right now talking to our health plan allies about a way to make sure that care is not dropped in the outpatient setting, whoever ultimately is responsible for following that patient. A lot of times, as I've said, it comes to the primary care physician. We do call people 3 months after starting an oral bisphosphonate. We have a list for that. And we monthly track data, but really what we care about really is where the fracture was. Do we know enough that this patient needs to be treated? Most of the time we do. For certain fractures where we don't have a DEXA, we need a DEXA because the DEXA is going to give us a T-score. If the DEXA shows low bone mass, a fracture that's not a hip or spine will be a yes fracture on the FRAX tool, and we may stratify that patient at high risk by FRAX. We've said that proximal humerus, distal forearm fractures, pelvic fractures in patients with low bone mass, that's a new clinical definition of osteoporosis. We think those patients need to be treated. But really what I would tell anyone is you have to create program-specific lists to get to care gaps. And you know, even though you can't get to all of these gaps, the more patients we retain, the more patients we treat and longitudinally follow, we're going to get to really the goals of the 2020 campaign, and I think we'll do better. We'll reduce the morbidity and mortality of this serious disease. Next slide. So I'm going to go over some data. So surprisingly, in our 2011 publication, about half of the patients choose to follow with us, but half follow with their primary care physician. More patients actually statistically follow with the primary in our area, really in our catchment area, 2 to 3 hours away from us centrally, but closer to our colleagues in the northeast sector of Pennsylvania or the central sector. They do follow with their Geisinger Health System primary, and we can follow and see if the right care gets done there. 10% get lost to follow-up. We weren't able to ascertain where they were. Again, what stimulates us to continue to pursue longitudinal follow-up is just the rate of treatment initiation in our pathway versus in their primary. We decided to simply see what's happening 6 months post-fracture. We simply did that programmatically, and in this initial publication, 15% of all patients were deceased 6 months post-fracture. So it points to the significant mortality and also the morbidity of osteoporosis. Next slide. Now, here's what I think we've learned. And what we've learned is we've not been able to solve all of these problems, but unless we know what they are, we have to try to continue to find solutions. We have certain hospitals now in our system where we don't have an inpatient fracture service. Well, we can at least find out who they are and try to get to them by fracture identification or by claims or by coding. A lot of FLS programs do it that way. So we're going to start to do what some programs do, and we're going to blend that with what we do by getting to those patients at our two major hospitals, our hospital in Danville and Wilkes-Barre. Communication is very important, and sometimes what we learn by looking at patients, by looking in our record, we either miscommunicate or we don't do what we say we're going to do. We know that patients don't sometimes make their appointments, and I guess one of the things that surprises us is the lack of engagement that patients have, or activation, or whatever you want to call it, despite really something really profoundly bad, a hip fracture, a pelvic fracture, a vertebral fracture, a proximal humerus fracture. Lack of consensus, we're not going to necessarily use the same medicine. To me, consensus in our system really comes today around which groups of high-risk patients would be treated a certain period of time, and no one has the answer to that. The issue of patients with chronic kidney disease, is there a level of chronic kidney disease where drugs have been studied, where we can use our therapies? For others, especially in lieu of data with certain agents, we're not sure, so that's something. And really, patients on steroids. American College of Rheumatology is going to come out with new updated steroid guidelines, but that's in 2017. I think there are issues with patients on chronic low-dose steroids who are on chronic anti-resorptive therapy, just like the typical long-term therapy issue. Those are three issues we're trying to develop a little more consensus. Scheduling, transportation, where patients are residing, and really patients lost to follow-up. One of the other things we've learned is even patients in our outpatient pathway after being seen in the hospital and really integrated into our outpatient pathway, we lose them. And we have to develop a way to find out why that occurs. Often they miss an appointment, we get a message, and we don't somehow codify that message or put something in our database that this is a patient at risk to be lost to follow-up. Next slide. Now, this is a fishbone diagram. I'm somewhat hard-headed, and I believe that the hambone diagram, which is a little more direct, gets you to a problem and a solution. But we have talked and brainstormed at length about why patients say no to us. Number one, I would tell anyone, don't take it personally. It is going to happen. And this is just, this has led to certain things we're doing differently to try to increase our follow-up rates, or patients agreeing to come to us and to try us out, if you will. But I think everyone has to do that. Without knowing that this was a problem with the data from the 2011 publication, we would not know that this problem, and then the problem of what's happening in primary care, that it even exists. It shouldn't surprise us, however, based on care gap data, and really based on what we know what happens when a patient is appropriately placed on an oral bisphosphonate in regular clinical care. Next slide. Now, what I did actually about a month ago is I wanted a list of the 2013 patients, and I looked at those patients seen in the first half of 2013. And what I found was that our follow-up rate, patients, about 40% followed with us, and now 60% opt to follow in primary care. Now, using a different mortality analysis, what I found was of those patients, 26% were deceased. But I can't say that that was at a 6-month time point, and I've not done, or we've not done an in-depth mortality analysis. Next slide. The other thing I did, and I presented this at the ISO meeting last year in Washington, D.C., I looked at men over 50 seen in consults since program inception through January of 2014. Men accounted for 25% of all fracture consults. Their follow-up was not as good. Their mortality at the 6-month time point was worse. It was 20%. Again, I'm in the process of actually trying to identify why. And just as with our overall population, we have a follow-up, a retention problem. And sometimes we can follow what happens in primary care, but a lot of times we can't because we're not integrated electronically with our surrounding primary care physician group that's not in our health system. So this is going to be a continued problem. And I wouldn't look at this as a problem, but as the initial way to answer or develop a solution to a problem that everyone is going to face. Next slide. Okay, I'm going to go through some of these a little faster. What we know is if we look at longitudinal care, we're very capable, and what we do with treatment is similar to what we reported in 2011. If we look at the group on the right, a larger percent of that group is really in primary care, and I don't really have access or the ability to see if, in fact, they were placed on medicine. And I was able to look at patients in our health system, but more of those patients were outside. So that's really, I mean, I wouldn't look at that and say, well, the problem is in primary care. The problem is just getting any patient and following them wherever they are. What we learned, though, is a lot of patients, about 40% of the original male population at some point in time died. So it's consistent with what we think to be an increased mortality and increased morbidity in men who fracture. Next slide. Now that just, we've seen lots of patients, and while we, based on 2011 publication data, we're likely to get that patient on treatment 8 out of 10 times, that's why we want to continue to do this and try to do it better. Next slide. So I think other archived webinars and other data with whether on the NBHA website or published or reported elsewhere, a programmatic FLS pathway allows you to risk stratify. Depending on how that ultimate population is followed, we're gonna report different things, but we know these are really at-risk patients. And I've tried to tell you we have a problem because most of our patients followed in primary care are outside of our own primary care network, and that really requires, I don't know what the strategy for that is. I do know the strategy is to look at what we're doing in our primary care network once we know they're not coming back with us, and we're specifically gonna look at our GHP patients because we have the resources and the help of the health plan in this cooperative effort to get better treatment rates. Next slide. Again, this just summarizes the problem. So we get to patients, they follow with us longitudinally, but as I've talked about, whether in our system or outside of our system, we lose those patients. And what we don't know is whether they're appropriately evaluated and treated. And that's, to me, where I think our focus has to be, to see if there's some way we can share ownership of an at-risk population and work to empower our primary care offices to be more efficient and effective with this, and to see if, in fact, that's a patient who needs parenteral therapy, that's maybe where we can help them a little bit more. Next slide. So I've talked about fracture exception reporting. We're working with 2 hospitals now trying to identify them without seeing them in the hospital and getting them into an outpatient care pathway. I can tell you I actually have a meeting tomorrow with our Chief Medical Officer of our health plan to see if we could develop some shared ownership and a strategy with our Geisinger Health Plan patients who we can use Geisinger Health Plan resources to get the right care done. We're trying to analyze men over 50 to really see what were the circumstances of death and morbidity. But again, I think established programs and programs that are starting will see that patients who are stratified, who are seen, will refuse what you're offering them, and what we can do with that population is going to be predicated by the different circumstances and the resources and the partnerships that one can develop to get that accomplished. Again, without some type of database and some type of metric, you really can't measure what you're doing and set goals to increase or improve your performance. Next slide. So I wouldn't have said this in 2008, but a database is important to measure the work, to coordinate the care, to capture what you think you're doing, to track, and really to help. Whether you want to have a consultative versus a longitudinal care program. Next slide. So if you were to ask me what are the most important metrics, what we should do when we see someone in the hospital is risk stratify. So yes, they have a femoral neck fracture, they have a vertebral compression, they've had a prior DEXA that shows a T-score of -2.5 or worse, and they've fractured. We need those patients treated. I think that the morbidity and mortality data is it's right in my face, and I really want to try to analyze that and help understand this. to help us and others maybe develop more effective solutions, because these are at-risk patients. And really, we obviously focus on whether we follow them or whether they're followed in primary care. The other thing we've shown is we've really been able to get vitamin D levels into a more acceptable range, and that's important because if you're on therapy and you have a replete vitamin D status, you'll respond better. Next slide. So, I mean, our program is fracture identification. We try to get that patient in the hospital setting to the outpatient setting. We have 3 major geographic hubs with primary care sites in between, where some of us will see patients. So we're trying to increase our accessibility. But we've clearly, in spite of this, identified what I would call program-specific barriers. And I think many of these barriers I have heard other programs that do very good work face similarly. Next slide. Whether it's an inpatient program or you're identifying patients by coding or by claims or by fracture, what you want to do is facilitate care in the outpatient setting. A lot of times the risk stratification, you know that they're a patient ideally who should be on a drug or should be recommended a drug. For some fractures, a DEX is needed. Communication, appointments, all of the barriers are really important. And I think when you're starting up, you have to assume that gaps are going to occur. Maybe one specific program and one specific or a certain type of healthcare system can get to some gaps better than others. But the primary care physician remains integral to this, because we know our patients and your patients like their primary care physician. Next slide. So Kaiser uses their database to develop safety nets. So our safety net is really, number one, does the patient say no to us? That's the biggest safety net. We know who they are. We then communicate to the primary. It's very hard for us to do more other than to work right now with GHP to see if we can help facilitate GHP resources to help. In our system, our health plan employs at least one registered nurse in every primary care office in our health system, and sometimes there are 2. That's a wonderful ally where we can send a communication to that nurse and primary care physician, and also a communication to some central area, and really say, let's see if we can work on this. If we can show success with that, we can, I think, with other resources, work to help our primary care colleagues. And again, maybe in past archives and maybe even on the NBHA website, Kaiser's been extremely gracious in sharing what they've done, but they use this concept because they know that gaps are going to occur in any system. Next slide. I'm going to actually try to conclude quickly. I've talked about most of this. We're going to go to the next slide. So my current solutions are, we're going to start to identify in some hospitals that we don't get to patients with fracture, and see if we can get some of them either into care with us anywhere in our system, or their primary, or their non-system primary. That's good. Whether coding and something specific to our own electronic health record can help us is another potential solution. We talked about fracture reporting and those ways of identifying patients and inviting them to outpatient care. Next slide. I talked about Geisinger Health Plan and what we're going to try to do there, and the fact that we have an ally, which is the Geisinger nurse in primary care dealing with Geisinger Health Plan patients with chronic medical problems. I think that's, I hope to be able to show over time that that's an easy way to fix some of the gaps we've discussed. Next slide. Now, the other patients outside of Geisinger Health Plan, that's not something we're forgetting about, but that's a little bit beyond what I think or what our system or what our teams can do right now, but we're not going to forget about that. What we can do is most effectively communicate when a patient refuses to follow in our pathway. Next slide. I'm going to try to learn about the men. Men fracture like women, and the morbidity and mortality is similar, if not worse. Next slide. So I'm going to conclude with life lessons. Number one, we get to patients who fracture. We see them. We think of recommendations. Follow a lot of these patients. Despite our best efforts, our patients want to follow in their primary care with their primary care physician. And I think we can be helpful to our primary care colleagues. And I think the way anyone can do this is different based on the way that they're integrated and the way they communicate. I continue to be surprised and perplexed by the lack of patient engagement. I mean, a hip fracture is a big shock to the system. It's a big shock to the extended family. One of the things I always try to do is ally with the family that happens to be there. I'm always pleased if family's there, because if I can make the case to follow up to the family, I think I can make the case ultimately and win that patient, or get that patient to follow with their primary care physician and at least think seriously about taking the drug that has been shown to reduce fracture risk. Next slide. Everybody sees patients who view the medicines as potentially more risky than anything else. Anyone who has a solution to that, I will listen to. I would again make mention of Kaiser's visual aids to explain risk. I think that that's sometimes simple and for certain patients very effective. But honestly, we have to continue attempts to identify and subsequently secondarily prevent fracture. And I thank everyone for listening to me. I'm sorry I went a little bit over, but I'd be happy to entertain any questions about what I talked about.
Great, thank you, Tom. I'm looking to see.
Question here about, so the task management software that we use is simply a Microsoft application. It's very simple. How we connect to our primary, we basically communicate to our primary care physicians electronically in our system or via fax or regular mail if they're not integrated with our system, but really they're not in our system, but they're impaneled by Geisinger Health Plan, or they have a different insurance. So the key is that communication, but I'll tell you, over the last 8 years, that's not enough, because we know even under the best of circumstances, someone in the office is going to see that, but the patient has to get back and be ready and willing to talk about that specific problem, and they often have other problems, and sometimes the bone health problem seems to always be a little bit lower down on the list, and it never makes it up to problem number one, or important enough or prioritized enough. I would contrast what we do with Kaiser. Has a very elegant system. Remember, they're one payer, we're multi-payer. Yes, we're integrated, but we see patients who have often non-Geisinger employed primary care physicians who see other specialists outside of our system, but if you look in our record, they're seen longitudinally for whatever, so we still have the ability to capture them. Be happy to answer any of the questions that that can be sent to me.
Great. It doesn't look like there are any other questions right now, but I would just like to add a big thank you, and then you see the emails up on the screen. So if you do have questions that you think of later, please do not hesitate to email me, and we'll make sure that we get them to Dr. Oleginski. So Dr. Oleginski, I'm sorry.
Yeah, I just want to say the NBHA website, I would encourage everyone to get access to that. Debbie can help you. It's a wonderful resource. and the archived webinars and other information is just phenomenally and practically useful. I appreciate everyone's attention and attendance today.
Great. Thank you so much, and thank you all for joining us today. The on-demand version of the webinar will be available on the Fracture Prevention Central website as well as the NBHA YouTube channel early next week. And if you could please take a moment and complete our evaluation that's going to pop up when this is over, we would greatly appreciate it. Thanks again, and have a great afternoon.